good afternoon, everybody. My name is Horst Neuhaus from Düsseldorf, and it's a great pleasure to moderate this very special satellite symposium together with my friend Alexander Repici, Digestive Endoscopy Center Humanitas University Hospital in Milan. So we are very grateful to Erbe to collaborate to organize this satellite symposium, and we have a very challenging topic. We're talking about the knife of the future, first human experience with a newly released Erbe hybrid flex knife. We have 4 lectures, so a very busy schedule, but outstanding speakers, and we would like to know what does this knife allow us to do and what is promising for the future. And doing that, I asked now Roberta Maselli, so the close co-worker from Alessandro, to give the first talk on hybrid technology in the third space, how to use the right knife. Roberta, thank you very much for coming.
Let me say I will try to defend a bit the standard hybrid knife, although we are starting a new era with this new knife. So you know that knives we have for the ESD, they are mainly divided in IT, insulation tip knife, and not insulated. And right now the hybrid knife is the only high pressure injection capable knife on the market. And they have both the O type for the IT and the T and I type for the non-insulated group. So we have these 3 types right now on the market, hybrid knife technology available to make the marking, inject, dissect, and also coagulate. But then they're coming with the new knife. So let's see a very short video, because then the other 3 speakers there will show you different application for the ESD and third space endoscopy. So we are here focusing on a smaller knife, thin pressure, thin precision, thin flexibility. And this is an ESD in the right colon, nearby the hepatic flexure. And I was so happy to have in my hand all the things I start saying to you about injection, dissection, coagulation, but with a smaller knife that give me also the chance to feel safe while dissecting in the colon. So when we have a thinner wall and very precisely going fast and safe. So what's the evidence right now for third space endoscopy and the hybrid knife technology? Starting with POEM, you know that everything I was mentioning, you can do it with the same knife. So once you are in the submucosa, you're able to precisely inject exactly where you want and make the injection in the submucosa, and keep on using the same knife. You can make the mucosa elevation, submucosal injection, but also then later on the myotomy. All the 4th step, you can do it with the same knife. So there's no knife exchange, and this is the brilliant concept of the hybrid knife technology. I'm not the only one who's saying. I have data that demonstrating that with this knife, the time of the procedure was significantly lower, and also minor bleeding episodes. Some other evidences. So with this knife, we had a decrease in POEM procedure time. But sometimes I ask, is time so important for us? Yes, it is, because the more the time you spend in a patient in a procedure, the more you can have adverse events, not only related to bleeding, but also the gas-related events and a lot of different adverse events. So the more you save time, the more you can be safe for your patient. Again, even in this one, you have a mean procedural time shorter with the hybrid knife technology. Again, fewer instrument exchanges, so only when you encounter a very big vessel and you have to exchange with a coagulation grasper, so only in that case you'll exchange the knife. Otherwise, you will keep on using only one single knife. Is it the same for other procedure? Yes, for example, in STIR, here we have an abstract when the average operation time required for the hybrid knife group was shorter, and also the time for intraoperative bleeding hemostasis was nicer. As for example here, we have a submucosal tumor just below the junction. That is exactly the let me say, not perfect, but the good time to have an endoscopic resection. So as you can see, with the same knife, safely and faster, I can arrive and reach the target point. I can export the tumor, and I can dissect nearby. And only some cases for big vessels, I will change it and using a coagulation grasper to have a nice hemostasis for my patient. And later on, I can remove completely the lesion in the submucosal space, and the final check, everything is fine, I can close the gap. Is it the same for esophageal ESD? Let me tell you that yes, you can do it, but maybe this will change with the HYBRIDknife flex. This is an example of a circumferential lesion in the esophagus. Here I'm using the I-type because this type of knife gives me more precision. So I'm expecting, and I'm curious also to see the video of my colleague, that with the HYBRIDknife flex, it will be much more precise, the results that I can achieve. But again, with the same knife, I'm able to mark, to inject, to enter in the submucosal space, make a dissection, and later on, step by step, to arrive to the final cut and remove my lesion. I've done also some ESD in the cardia. You know that here, the problem is that most of the time you are working in retroflexion, and a lot of people is thinking that the HYBRIDknife flex is too rigid and it's difficult to work in retroflexion. Well, it is true, but at the same time, I'm provocating saying that is a flexible rigidity. So sometimes you can even work with the HYBRIDknife, make the same marking, injection, dissection, and working both in retroflexion and in frontal view. But I'm expecting that with the flex, this will be much easier. Gastric ESD, I have some evidences. Even here, the HYBRIDknife flex has been demonstrated to have a significantly shorter procedure time, and also the changes of accessory, as we were saying for other tract, was less frequently. And finally, this is a very nice paper from my chair, Horst Neuhaus. It simplifies ESD. I like this definition because ESD is a third space endoscopy procedure. They're a very complex procedure, and we must try to make it as simple as possible. So the question here has, do we need a different device? If I ask people not working with HYBRIDknife, I heard words like, it's too rigid, there's no precise mucosal cutting, it's too long, it's too big. But let me focus a little bit on coagulation of blood vessels. You know that if you have a large contact surface in between the vessel and the knife, the more you can have the power to make the hemostasis. And with some specific coagulation property, like for example the precise sect, you can make the right step in having a successful and effective hemostasis. That is basically 3 steps. So it's vessel detection, and for this you need to inject. I will show you a short video. Vessel preparation, to be able to cut nearby the vessel without touching the vessel. This is why the knife should be precise. And finally, vessel coagulation. This is what I call with the precise sect mode, one device ESD, because as I was saying, the first step is inject nearby the vessel to make a nice detection, and then with a precise knife, you have to prepare the vessel, dissecting all around the vessel, trying not to directly cut the vessel. The vessel starting to whitish, that means that we are sending some current in the vessel. And only once we are really prepared the vessel and expose the vessel to our knife, we can go there and make an effective hemostasis. So from this point of view, let me say that maybe a big knife for big vessels. So here we have to understand the right indication for each knife that we can have in our toolbox. And after make the preparation, we can grasp a bit and coagulate in the middle of the vessel to seal completely the vessel we are facing. And we repeat the step all the time because without changing the current, the precise sect is known as the artificial intelligence of the coagulation modes, because it can compromise and change the power depending on the tissue we are encountering. So without changing knife and without changing even the coagulation mode, we can proceed and make our third space procedure. So my key message is that, let's say that on the left, you have the flexible rigidity from the standard hybrid knife. But on the right, you have a fast and safe procedure that both of them, the flex and the standard, can be achieved. Maybe big knife for big vessels, but for sure the custom injection that both of them gives you that make the difference. So let's say that maybe the flexible rigidity is still very good for POEM, STER, maybe in the rectum when we have very big vessels, maybe distal stomach. And say maybe because from now that we are launching it, we need data and we need to demonstrate where is the best use for both of them. But what about, and I didn't mention that, colon, esophagus, proximal stomach. So maybe there, the flex that is fast and safe, but still have the custom injection. But here, we will add precision and flexibility. Maybe here we can use this one. Thank you.
Thank you, Roberta, for your very well please stay forward. Yeah, for a very well balanced presentation, showing what this knife allows us to do and what kind of advantages it offers. Are there any questions? Are there still cases where you prefer the legacy, the thicker hybrid knife?
Yes. Into distal rectum, when I have a lot of vessels, for sure for POEM, because that rigidity in the esophagus is very good. And then for the other track, we'll see. For sure, in colon, I would prefer the flex knife.
And just to know how to choose T and I type, what is your preference and what are the criteria for selecting the type of the knife?
Yeah, as I shown in the video, the I type till now I use mainly in the esophagus when you need a very precise dissection. Meanwhile, the T type is when you need both by pushing a bit and dissecting, but also to grasp the tissue, because the T type is similar to a nook.
Yeah.
That you can grasp the tissue and then cut it. So when you need both, it's better the T type. For the two, if I have to decide between the two, my preference one goes to the T type, but at the same time, sometimes I switch to the I type, for example, in the esophagus.
Okay, thank you very much again.
So now next is, but we are not noticing. Okay, it's not you. So. A question, okay, go ahead for the question. So, Mika.
One more question.
So, Roberta, you tried to defend this knife, saying that there is much more coagulation, which helps to seal the vessels, which is like logical thing. But on the other,
normally Roberta is an attacker.
Yeah,
so it's unusual defending.
Yeah, so on the other hand, I mean, what we don't like about the former knife is that you have too much coagulation when you do the incision or when you do the dissection in the submucosa without vessels. So I think that in there the new shorter and thinner knife is an advantage. Don't you think so? Just to challenge you a little.
Yeah, sure. I completely agree. And this is what I was mentioning when I said precision of the mucosal cutting. I do agree that this knife, because is longer and stiffer, makes you not precise mucosal cutting. But still, there are some places when that one is not the main part. Like, for example, in POEM, when the mucosal incision is just to enter in the submucosa, we are not removing tumors. So it is a different point of view. There's still place for both.
And the fixed length of 1.5 millimeters, whereas the legacy is always going further back and so on. Yeah, thank you very much again. So we have to move forward.
Okay, thank you. Thanks, Roberta. And now it's my pleasure to introduce Dr. Leclercq, who is going to talk about pushing the boundaries for colorectal ESD. Philippe, it's your time.
So thank you very much for the invitation. So my task is to talk about colorectal ESD, and we will probably more focus on colonic ESD. So these are my conflicts of interest. I have a good relationship with these two people.
It is very conflicting.
Yes, exactly. So on the left you have Michael Bork, and on the right you have Jérémy Jacques, two key opinion leaders respectively in piecemeal EMR and ESD, and I want to keep a very good relationship with them. So choosing and decision-making between piecemeal EMR and ESD is not a matter of a religion. In God we may trust, all other must bring data, and that's why we will see. So for piecemeal EMR, it's widely available, safe, fast, with low cost at baseline, not dependent on location, but with less optimal histological assessment, high local recurrence rate. On the opposite, ESD provide en bloc and R0 resection with optimal histological assessment, low recurrence rate, but we need more expertise. It takes longer time, more complication, higher cost, and more difficult, and even much more difficult in the colon. But there is no carcinological reason to choose and to push piecemeal EMR over ESD, because we all want to have an en bloc resection for these lesions. So what the science say? So let's go to that study published by Michael Burke, who showed that piecemeal EMR associated with margin thermoablation will reduce to a very minimal rate the recurrence rate, with a very low rate of perforation, with a minimal time of the procedure. But if we see exactly the same technique published in another study setting by the Dutch group, we can see that we have the recurrence rate more than 2 times more. So these results are not perfectly reproducible, even with proper training and massive use of thermal ablation of the margin. If we compare now the piecemeal EMR with the ESD, we have that recently released a randomized controlled trial published by Jérémy Jacques, who showed that ESD can provide a high rate of R0 resection with a very low rate of recurrence and with an acceptable level of complication, especially needs for surgery because of perforation. But if we go to another recent published study on colorectal ESD, published by our Dutch colleague, we can see that we do not face to the same results with lower R0 recurrence, with lower R0 rate, with higher recurrence and higher perforation rate. So the question is now, are these French results reproducible? We need data for that. And last year, Ludovico Alfarone from Professor Repici team conducted a study from a cohort study from France.
We are invading France.
Yes, exactly. And during 3 years, they recruited almost 4,000 patients for colorectal ESD with 29 operators. And we can see that the results are comparable to those published in Annals of Internal Medicine. So for the randomized controlled trial. So the procedure time is low, the R0 resection rate is high, and the need for surgery is low. And you can see it's not only a few patients, it's a huge amount of lesion in a short period of time. It's not only 1 or 2 expert operator, but the virus is coming over and over and over the world. So what say the ESGE? The ESGE recommend en bloc resection for all the lesions who can harbor submucosal invasion, at least shallow submucosal invasion. And it's based on the on the optical assessment of the lesion, especially the gross morphology features. But we also know that it's very difficult to predict that submucosal invasion based on that, because in half of the cases, while using only the gross morphological features, we will miss the submucosal cancer. And what about the GNet classification, and especially for those GNet 2B lesions? It's the same. We have a very nice study comparing the result from Japanese and European experts that showed that GNet 2B has a very low sensitivity and very low specificity to predict the submucosal invasion. We have also the Connect classification developed by the French guy, who increase massively the sensitivity, but it will promote the ESD because the specificity is very low. So you will have to resect all the patient, almost all the patient with ESD. So as a conclusion, ESD can be a good oncological treatment, but the selective approach is still missing good tools to predict the lesion invasion. ESD can lower the risk of local recurrence and could also lower the number of surveillance colonoscopy. There is still a problem, the longer time. It takes a long time to do the procedure, especially at the beginning, and we have more complication. And for that, it's not a carcinological region that will push the piecemeal EMR against ESD, but it's the time. And we need more tools, and that's why we need all these tools developed, for example, by Erbe. This knife will dramatically increase the time procedure because, as explained by Roberta, you don't have to change always your knife. Here it's rectal lesion, and you can see now the mucosal incision. You can see that you don't need to use a needle to reopen. And now, after the first mucosal incision, we will go for the trimming and see now all these vessels and how fast it is, because we are using also Precisect, and with Precisect we don't care about all these vessels. They will be automatically coagulated by the system. Okay, see how fast it is. You see all these big vessels. Before you had to use a coag grasper or something like that, but it's also working underwater, and it's very important to work underwater in some situation. And in underwater you can directly inject and discover that wonderful plane and cut underwater, and not all the knives are able to do that. So it's very important and very safe. See, a vessel is bleeding now. You don't have to change. You just inject a little bit more to secure your plan and to prepare your pre-coagulation with Precisect. So the Precisect helps you to do a preventive coagulation of the vessel, as shown by Roberta, and then it's completely cut, and you don't have to change anything. So, okay, let's go to the next one.
May you introduce me?
You introduce cost.
Okay.
Voilà. Here it's in the colon, okay? This is the lesion. We did the injection with the knife. This is the mucosal incision. So believe me, I'm not the best endoscopic in the world, and even me, I'm able to do colonic ESD with all these tips and tricks. So the knife allows you to have a very, very secure submucosal cushion to do the full circumferential incision. And now we will see what we learned from our French colleagues and friends. So this is the second tips that we really need, because as I already said, I'm not the best one. I'm not able I was not able to dissect into the colon before that tips. So we use the rubber band, the traction, and then we will see now you have the third end. You have your assistant that's pulling the lesion, and you will see how easy it is. Not always, I have to admit, but now you will be able to expose completely the plan and re-inject during the procedure. Some situations are still difficult. For example, here some fibrosis under the lesion, and with the knife you will have the possibility to have a very powerful injection of the submucosal plan, and then one more injection. You can inject as much as you want, and you have all these very nice submucosa, and this is the end. And in this situation, I really like the new knife, because especially the T-type, because you can hook the fibers and it's done like this. Okay. So at the end, it's an happy end story, because we are all friends and we are all pushing the boundaries of colorectal ESD. Thank you very much for your...
Thank you, beautiful lecture. I don't know if it's a matter of a name. You know that Leclerc is the pilot of a Ferrari in Formula One. You are as fast as Ferrari. Congratulations. Very nice.
Thanks to iMovie.
So, again, I've been using your flex knife very, very nicely into the colon. Can you give us your personal thought? What is your feeling with the flex knife, especially for colorectal ESD?
So, I at the beginning, I used the old knife from Erbe, and I had exactly the same issue that Roberta explained: the rigidity, the lack of retroflexion, and the length also of the tip of the knife. But now the new knife, I I was doing all my procedure with dual knife, but now I'm feeling exactly the same than dual knife, but with a completely different advantage is that completely amazing and powerful injection during the whole procedure. And if you don't feel very comfortable with ESD, you need to inject, and it's usually difficult with the other knife. So that's the main issue and the main advantage. And the other advantage is the precise sect. The precise sect helps you to avoid bleeding during the whole procedure, and it's a very difficult thing when you start doing ESD. It's managing all this bleeding.
So with your outstanding technique, you obviously very rarely have a bleeding, but you may have it. And do you appreciate that also the catheter is thinner so that you have space for suction? This, I think, was a limitation of hybrid legacy. You block the channel. You can, with a diagnostic scope, you cannot get rid of the blood.
Exactly. And the other thing is that soft coagulation is working very well with the tip of the knife, and you can really nicely coagulate the vessel with soft coagulation without taking a coag grasper, for example. So it's another big advantage. Especially with the T-type, soft coagulation is coagulating even very big vessels that are bleeding in front of you, and you can inject to expose exactly the vessel.
And spray coag, yeah. Okay.
Okay, good. Thank you so much. It's now time to move. And now I want to introduce the chairman of this beautiful meeting in Düsseldorf, Professor Thorsten Beyna. Thanks for joining us. Your topic is esophageal ESD, and we're ready to learn from you.
Thank you for this kind introduction. So first of all, I have to apologize. So obviously my last procedure in the hospital took longer, and I should have taken the hybrid knife. Then I would have...
You choose the wrong knife. That was the problem.
So we keep this in mind while I have my lecture on esophageal ESD, how we can optimize. So we know the background is that we have to perform endoscopic resection for most of our, we can perform it for early GI neoplasia, including the ones with cancer without signs of deep submucosal invasion. And we need en bloc resection for most of the cases, and this can be done by ESD in most of the cases. We definitely need a pre-therapeutic assessment of the lesions that we can decide what type of therapy we have to apply. In most cases, we have to admit we have to perform also in Western patients and Western centers perform ESD. So when we have a look at our guidelines, European guidelines, as you can see, for squamous cell carcinoma, we need definitely en bloc resection ESD. It's clearly shown also by this study from French centers that it's clearly superior to EMR technique in terms of curative resection, recurrence rate, and also 5-year survival rate. And in terms of early adenocarcinoma, it's of course for flat dysplastic areas we can perform, as today was nicely shown by Pratik Sharma, multiband EMR, but for malignant lesions that especially the larger ones and also the ones that have a high suspicion of submucosal invasion or scarring below, we have to perform ESD in these cases as well. So ESD procedure is a difficult procedure, and it's more prone to complications than other techniques, and these are mainly related to perforation and bleeding. And in Western countries, we are still learning and developing. There's high expertise in some centers, but not everywhere. And I think the number of ESD procedures has to go up, and now we have technical developments that make ESD easier, faster, and safer in the future. What do we need for esophageal ESD? Definitely, we need a small caliber instrument, a flexible instrument that fits into this 2.8 millimeter working channel that preserves the maneuverability of the scope and also the suction capability that was already mentioned. We want to have a tiny active electrode that is comparable, as mentioned before, to the dual knife that used to be the gold standard in terms of this electrode. And this should maintain a stable position during the procedure independently of the scope's position. And then we want to have controlled high pressure injection through the tip of the knife. That makes also the difference in hybrid knife compared to other devices. There's also challenges in terms of the current that we want to apply. So we need a precise cutting for the mucosal incision. We want to have effective dissection of submucosal fibers without affecting the backside of the mucosa, of course, and we need a safe and reliable coagulation current. And this was a slide from a previous presentation, so not all of these needs can be met with one instrument. So I have a new slide. Now I think all of these needs can be met with one instrument. And this clearly changed. So this was shown, I think, in the presentations before. We have, this is a legacy hybrid knife, this is hybrid knife flex, very tiny electrode. We can do a very precise cutting and coagulation here using the device. This was also discussed. We have a bulge tip that this is for the stable position within the working channel. But if you push the knife out of the working channel, you have the thinner shaft in the working channel, and this then creates this suction capability that was already mentioned, also with a diagnostic scope in a bleeding patient, for example. So I think in combination with the YO3 generator that comes with all the different cutting and also coagulation modes, and here we, together with the Erbe jet, I think we can expect also the new jet to arrive soon. But I think it's a perfect match for us, in especially also esophageal ESD, but everywhere in the GI tract. And so let's have a look. How can we optimize ESD technique? We have here a squamous carcinoma. So first, of course, we have to identify the boundaries of the lesion, and then we have to mark the lesion. And again, here it's very important that underwater technique is working with a current and with a knife. Here we can precisely delineate the lesion and use here forced coagulation for precise marking, for example. So the next step is that we plan our resection. So usually we can, with the hybrid knife, we can go relatively straightforward because we have this high power injection, but usually it's very good to have a strategy. So my strategy is that we use this, what some may call this double J incision technique, for example. So I modified it a little bit. So I usually start at the distal part of the tumor to have a horizontal cut here, and then two J-shaped cuts on the left and right side of the tumor, here and here. And after that, so I go back and do another cut here to perform a complete circumferential incision of the mucosa. So of course, we can do for tunneling go for tunneling technique, but using hybrid knives, this is not necessary in my opinion. So if we want, we can preserve two mucosal flaps on the left and right hand side to preserve some traction, but this is not always necessary. So this is then the result here, circumferential incision. So we can watch the procedure. So again, I think it's very important that we don't need a needle anymore. We just use the coagulation markers as nicely demonstrated in the morning, and then inject, and then you can see the nice cushion that we create just by tapping on the pedal of the Erbe jet, and this creates this nice cushion where we can then cut on top of it. So here, okay, we can skip this. This is only, so this was the first J, and then we go to the upper part. And again, we don't need any needle injection. We can also, sometimes it's nice for procedures, and most of the time I use gelafondin as an injection solution, but you can work with normal saline because now we have on-demand injection. So we don't need to inject the whole lesion at once, but we can have it on demand every time we need it. And finally, we end up here, full circumferential incision of the muscle. Hopefully not of the muscle, of the mucosa, of course. And here, so this is where we come from. So it's again very helpful also in the esophagus if the patient is intubated to use underwater technique. We have very clear boundaries here of our resection plane. We can see the vessels easily, and then we can continue. So injection here through the tip of the knife is again very effective also in the underwater technique, and then you can cut. For example, you can also use dry cut. You can use precise cut. Precise sect is a little bit difficult underwater, is at least my experience, where it works very well in all parts of the colon. So, but in your experience, obviously it works very well. Huh? But we use here dry cut and spray coagulation. So it obviously also works here with high pressure injection without underwater technique, very effective. And then finally, if I find it correctly here, you have the final stalk here. So obviously this is possible to resect also these larger lesions. And so I think underwater technique can be really helpful here. This is, some may call it the saline immersion technique or water pressure method or whatever. It's underwater or under saline, and this works very well to identify all the different layers and to identify your cutting plane. It also prevents dusting. When you have fatty tissue, if you cut it or coagulate it, then you have everything in front of you on your lens, and this can be really disturbing. And this is also prevented by underwater technique. Still, traction strategies are very helpful. Here in this case, a clip and string method. You can also use rubber bands, but in the esophagus, clip string is my preferred method because you can take it from outside. And so, of course, we can go for tunneling technique. This is only a short video just to show you here what we can do. So here, 2 tunnels for circumferential resection. Then you incise the distal margins, and again, here we can then perform the complete resection, and then we have complete resection of the circumferential area. So in summary, what do we need? What don't we need anymore in the future? So I think needle injection, we don't need needles anymore. We don't have to change the instruments. We don't need different types of knives for different locations. We don't need expensive lifting agents. And of course, we don't in routine use the coagulation forceps anymore. So this, on the other hand, still very useful, is a strategy from the beginning that has to be adapted to location, lesion size, and the risk of perforation and bleeding, and also previous treatment. Gravity is also very important to keep in mind, and traction is helpful as well. And never stop learning. It's important to refine your technique according to new developments in the future. So thank you very much for your kind attention.
Thank you, Thorsten. Very beautiful. So may I make a comment? I want to see what is your comment as well. So it looks like now not only esophageal, but mostly esophageal. So water is a main factor. We use underwater, we use water pressure. So in the past, we didn't value water as much as we're doing right now.
Yeah, that's a very good comment, because we totally changed our attitude to ESD. So in most of the locations, at least main parts of the procedure of the dissection are done underwater, and with all the advantages that I mentioned before. So of course in the esophagus this can only be done if the patient is intubated, but this is very helpful. Yeah,
a very good combination of underwater plus water pressure.
Yeah. There's a question from Jürgen.
Thorsten Wonder. In 2013 and 2030, and I'm that the new knife is out. Do you think the randomized trial by again would have resulted in the same results today?
Yeah. It's difficult to tell, and I cannot go into detail because at that point I was not part of the Düsseldorf team. Maybe this could also be an issue, but yeah, I think the ESD technique has become more and more. So we are more and more experienced in doing ESD. We do most of the cases of proven malignant lesions with ESD. So maybe we could have different results nowadays. However, it will be difficult, as we discussed several times, to have a randomized trial, and to which endpoint will be maybe difficult. But
it's a clearly better knife.
Yeah, definitely.
Okay, thank you very much.
Thank you.
We're coming to the last lecture. Michael Kaminski, we are very much appreciate that you come from the Oncological Center Institute in Warsaw, and you talk about endoscopic intramuscular dissection in the rectum using the hybrid flex knife.
Yeah, thank you so much, Horst. Thank you to all. So I fully agree with Philippe, who said that we need data on what we are doing, but when we look for the future, like with a hybrid flex or endoscopic intermuscular dissection, we actually don't have a data right now. We have to collect it in the future. So I'm going to give you some of the insight on how the future can look like with a new kind of procedure and using a new knife as well. So this endoscopic intermuscular dissection became an idea when we realized that those patients who had deeply invasive submucosal cancer without any other risk features, they have relatively low risk of lymph node metastasis, around 2.5%, which is relatively low. So for those patients who had lesions in a distal rectum, there was no other choice other than surgery or maybe radiotherapy to treat those lesions if they invaded deep submucosal layers. So I just want to show you a video and share you this case of a distal rectal lesion. It's located around 3 centimeters from the anal verge. You can see the lesion is relatively small, around 15 millimeters in size, but it has a clear depression in the middle, a clear demarcation line. And when we will look in first LCI and then BLI in the middle of the lesion, you can really easily understand it's a JNET3 type lesion, which tells us that this is most likely a deeply submucosal invasive cancer. So for this kind of lesion, standard ESD technique will likely render R1 resection. Therefore, we want to go one layer down and go in between the layer. So we start after the careful assessment. We start with a hybrid flex knife, this type T-type knife, 2 millimeters in size. You can, as you have seen already, you can inject easily, and immediately after that, without exchanging between needle and knife, you can perform incision. While you already incise, you can expose circular muscle layer in the rectum. So what we are going to do next, we are going to incise this first layer, because we have circular muscle layer and longitudinal muscle layer underneath in distal rectal lesions. So here we come and we start dissecting the circular muscle layer, and in a minute you'll really easily recognize these two layers. So underneath you can really easily spot that there is a longitudinal muscle. So here we have circular muscle layer. In here we have longitudinal muscle layer at the top, and this is the space in between, because there is a space, especially if you use a knife like hybrid flex, to inject in between and split these two layers of muscles. So you can use also a new wire-free with a precise cut, a precise sect, and just to dissect in between. You can use this powerful injection to split two muscle layers, and also you can, as has already been shown, you can play around with your diathermy settings. You can go down with precise sec to 0.6, and even an artery going in between the muscle, you can easily step by step cut through with a knife. So no need, as mentioned before, for car graspers anymore. And then you go back to precise sect 5. These are the settings that at least I'm using just to split these two layers of muscle. Just to explain you a little bit how it looks like. So we go underneath, we enter this space. So we are in here, in between two layers of muscles. Here you can see some of the tiny vessels underneath the lesion, and here we have also to go outside from this tunnel that we created toward the regular rectum. So we are right now cutting again the circular muscle layer to communicate and to create a full tunnel. Once we achieve this, we will just cut the both sides or lateral side of the lesion, and you can see that we are cutting right now all three layers. So the muscle layer, the submucosa, and the mucosa all together, because it's relatively easy to make it happen. And what was already mentioned before, that with the use of a hybrid knife, if you have a small bleeding, you can aid the hemostasis by the use of injection and then coagulation, and you can easily stop the bleeding vessel. And you can right now really appreciate these three layers. So first we cut muscle, then we cut submucosa and mucosa, and you can complete the incision from both sides, and honestly speaking, remove those lesions quite easily and swiftly. So what you can see here are at the top, the circular muscle layer. In the middle, you can see the longitudinal muscle fibers. Sometimes you can see some of the split of those muscle fibers, longitudinal muscle fibers, but they don't cause anything bad. And like with this procedure and this patient, it was, as you can see, really crucial to remove it with intermuscular dissection, because this was a adenocarcinoma G2 without lymphovascular invasion, without perineural invasion, with low budding and no poorly differentiated clusters, but with a deep invasion of submucosa, without invasion of muscularis propria, and R0 resection was preserved. So this was the one of the only chances for cure for this kind of a patient. The alternative would be to go for surgery or radiotherapy. Thank you so much.
Yeah, thank you for your excellent presentation and also explanation of the technique. In your hands, it looks quite easy. Could you please just comment, how do you select now patients for the intramuscular dissection, and what is the impact on the procedural duration?
Thank you so much, Horst. I mean, it's a very good question, because it's a tough one. It's the most difficult thing about intermuscular dissection, because we have those classification that allow us to differentiate between superficial submucosal invasion and deep submucosal invasion. So as with this kind of a lesion, you cannot fully rely on JNET, because you have a JNET free, so it could be SM free, and it could be also a T2 cancer. So honestly speaking, what I do for those rectal lesions, I do something very simple, what our radiotherapists are doing a lot. So I do a digital rectal examination as well, just to feel if the lesion is mobile. When the lesion is mobile on your digital rectal examination, it is most likely that it will be a still SM or T1 cancer. So this is something, but we really need to refine our criteria to better select those lesions, because you will encounter some of T2 cancers as well. So with regard to the second question that you had, I think that it's a pretty straightforward and fast technique. Honestly speaking, I was a little bit surprised to see that, splitting those two muscle fibers is easy. You have only these big vessels in between, no small vessels, no scarring, no fatty tissue usually. So honestly speaking, the dissection goes really smooth and efficient. So I wouldn't say that it adds a lot to a procedure time as compared to a standard ESD, maybe 10 minutes.
Okay, thank you. And final comment or question from Philip?
I have a question about the location where you can do that and where you cannot do that. For example, the upper third of the rectum or the anterior wall of the rectum. Is it feasible in this situation?
Yes, that's a brilliant question, obviously. In order to understand where you can do that, it's the most effective way is to do MRI, because when you do MRI on this patient with a proven rectal cancer, you will see where the peritoneum start, because obviously you can do this this procedure where there is a mesorectum outside, not a peritoneum. It means that usually up to 10, 12 centimeters you can do that, but obviously there is a variation between patients, so you need to do MRI to understand if you can proceed with such a procedure. So this is how it works. Your second, if you can remind me the second part. Okay.
Okay, thank you, Mika. Thanks, very brilliant. I'm not sure it's so easy, but it's very brilliant. So we got at the end. Thank you to everybody who joined the meeting. It was very nice. Thanks to the speakers, very brilliant presentations and beautiful videos. And especially we enjoyed the fact there is a sort of big change. It's a revolution in ESD. Now we have a device that allows us to do things much better, probably safer, and also easier. So thanks, Erbe, for supporting us once again. And I wish you a very good rest of the meeting in Düsseldorf.